Hello, everyone. Welcome back to another CP Solvers Tuesday virtual morning report. I'm really excited today to discuss with a CP Solvers legend who everybody knows, I hope by now, and that is Kirtan. Kirtan apparently started a diagnostic secret consult service on his hospital where people send him mystery cases for him to solve, and he's gonna share with us his brilliance today. Kirtan, you wanna introduce yourself?
Sure, thank you for the kind introduction, Yusuf. And I wanted to tell everybody that, we have nicknames for everyone in our community. So for Yusuf, the nickname which I have is Master Yusuf because he is really the master. Like he actually came up with this brilliant plan of management, reasoning VMRs, and that has been kind of like the pioneer thing for CP solvers community. So I really I admire him. So I am fortunate to discuss with him. Initially, I was planned to discuss with Dr. Singh, but then he was not able to make it. So Yusuf stepped in. So thank you for stepping up, Yusuf. I'm excited to discuss the case today with you. And I now want to introduce everybody to Erin, our first time case presenter. She is MS4 going for emergency medicine. So we are so fortunate to have you, Erin, with us. Do you want to tell us a little bit about what are your hobbies outside of medicine?
Sure, yeah. Hi, I'm Erin. I'm really excited to be here. I am coming here from Florida. I go to Lecon Bradenton. I'm a fourth year applying for the emergency medicine match. Pretty excited to present this case to you guys today. My hobbies, I like to run. I actually was just convinced by my roommate to sign up for a marathon. We'll see if that is something I'm going to regret or not, but I'm starting training for a marathon in January.
That's awesome. Thank you so much for sharing that, Erin. And I also wanted to thank Vale for helping with the scribing today and Vinicius for doing the teaching points. So whenever you guys are ready, we can get started with the first aliquot.
Just give me 1 second. I'm gonna share my screen. Okay.
Okay, I'll go ahead and start. So for our chief complaint, we have a 60-year-old male who presented to the emergency department via EMS due to near syncope and a fall. Would you like me to keep going or do you want to pause here?
You can give us more data, Erin. That's fine.
Give you more? Okay.
Yes.
So the history is provided by the patient's daughter. So per the patient's daughter, he woke up today with altered mental status, describing it as just a confusion, being out of it. She noticed some slurred speech, nausea, and weakness, leading him to nearly passing out and falling. She denies any loss of consciousness, but endorses significant confusion. Give you a little more. So for the past week, he has actually not been feeling well. He's had symptoms of fatigue, lightheadedness, multiple episodes of non-bloody emesis. And for the past 2 days, these symptoms have been progressively worsening. He has become increasingly confused, weak, and beginning to appear jaundiced. And just to summarize some of the pertinent positives, he emits the doctor states he has malaise, fatigue, weakness, diaphoresis, nausea, vomiting, memory loss, and confusion. Some pertinent negatives, we have no headache, no dizziness, no abdominal pain, chest pain, dyspnea, no jerky movements, no bowel changes, and no hematemesis. And that's the end of aliquot 1.
Well, thank you so much, Erin. What a start to the case. It sounds like we have a 60-year-old gentleman who's been having a subacute 1-week history of not feeling well, vomiting, and confusion. And confusion oftentimes is the center of gravity of a case, and sometimes it's not the center of gravity of a case. And the way we decide that depends on the risk factors. For example, if you told me this was a 85-year-old gentleman who presents with 1 week of confusion, I would definitely say the confusion is not necessarily the center of the case, because then they're at risk for delirium, because older age is a risk factor for delirium, prior delirium is also a risk factor, or dementia is also a risk factor. But here we have a history of a 60-year-old gentleman, and that's a pretty young age, which is very concerning for me. And which makes it very severe. It makes me really want to explain this encephalopathy. I wouldn't just say off the bat, this is just delirium. And to try to focus of whether this is intra-CNS or outside the CNS, we see some signs that like vomiting and jaundice that are associated with the encephalopathy. Now, how do we associate vomiting and jaundice with increased ICP? There are many ways to associate these two. So one way could be, for example, an increased intracranial pressure causing vomiting. That's like one pathway. Another pathway could this patient just have sepsis, which sepsis on its own could cause a cholestatic pattern and some encephalopathy. Could this be TTP? This is all like very broad. But I'm really worried about this gentleman. I'm also worried that this could be an intra-CNS process. Could this be a stroke? Because as you know, as you're applying for the ER, any encephalopathy should be treated like a stroke, or because if there's something that is reversible, you do want to reverse it as soon as possible. Maybe, but the other thing that comes to mind is that if this has been going on for a week, even if it is a stroke, it will less likely be something that's we're gonna treat with like a thrombectomy or anything intra-CNS. But I foresee that anyone seeing this patient is gonna think about imaging earlier rather than later because of the risk factors. I'm gonna pause there. What do you think, Kirtan?
Perfect. Yusuf, I love your approach, that the way you laid down the type 1 thinking and type 2 thinking. Like you first went down the normal big buckets of what could be going on, and then you did some reflex association that could this be stroke, could this be TTP. So I think I can just add to that, that the big approach which we always use is we try to rule out the reversible causes, and then we go to the more non-reversible or the structural causes. So for example, whenever somebody comes with so-called confusion and a subacute course, we want to rule out the metabolic stuff. So what does that mean? By metabolic stuff, I mean, we want to look at the electrolytes. We want to make sure sodium, potassium, calcium, phosphorus, magnesium are good, because higher levels or lower levels of any of them can do this. Then I want to know the basic chemistries. Like, do you think this person's liver is failing and they have hyperammonemia? Do we think this person's kidneys are failing and they have uremia? And both of them will come under the metabolic bucket. Do you think this person's thyroid is going crazy and the patient is in thyroid storm in some way? And is it causing this? So under the metabolic bucket, we will also have thyroid and the cortisol axis. So we'll think about that. We'll also want to look at the glucose as well. That what if this person is just acutely sick from something else, but now eventually the liver is failing and kidneys are failing. So their glucose stores are running out. And maybe this acute on subacute confusion is related to hypoglycemia. So this will be the metabolic bucket. And then we go to the must not miss categories of infections. So like Yusuf was saying, that is the problem in the brain or outside the brain? So the most dire consequences could arise by missing meningoencephalitis or brain abscess. So imaging is priority, as Yusuf said. The other things, is it possible that the patient just has run-of-the-mill sepsis, which has now affected the global cognition, and that is why the patient is altered? So sepsis, pneumonia, pyelonephritis, liver failure, kidney failure. This will be like the big organs under the infection bucket, which could cause this. Then we go to the non-infectious causes, which can hit the CNS. So the big things which I think about is what can go wrong with the blood vessels, what can go wrong with the blood, which is inside the blood vessels, what can go wrong with the parenchyma itself. So what can go wrong with the blood? So Yusuf highlighted the most important causes. That is this some kind of microangiopathic hemolytic anemias like TTP, HUS, because all of these things can cause diffuse clotting and hyperviscosity, which can present with jaundice as well as altered mental status. The other big thing would be, is there some sort of infectious hemolysis going on? Is it possible that patient has, let's say, malaria or babesia, which is causing this jaundice and now affecting the CNS? So like jaundice versus very dire consequences, you immediately think about liver failure versus hemolytic causes like TTP and all these infections. And then rarely, sometimes it can happen that patient has some toxic exposure, which we are not aware of. So it would be interesting to see that what are the medications that patient has been taking, what are the exposures that patient has, and are there any over-the-counter things or substance abuse which patient has been doing. So with this big approach, I think we can narrow down our differentials. So excited to hear more.
Kirtan, I had a question for you. You know how the patient appeared jaundiced, so that means that their bilirubin was at least elevated, or maybe we're assuming. Does that make you think of like liver versus hemolysis? Does that sway you one way or the other, or it doesn't?
So that's a good question. And now the question becomes that when we say patient appears jaundice, which side we are talking about? Like, are you talking about their eyes being yellow or their skin being yellow, right? Because we know that bilirubin at different levels can hit different things. And in general, we know that as long as your liver is able to function fine, hemolysis cannot cause direct bilirubin levels of above 5 because your body will be able to metabolize it. But here is the catch that since patient has been suffering subacutely, it is possible that whatever was the underlying process, maybe by virtue of ischemia, it has affected the liver itself. So something which was extrahepatic now has transformed into intrahepatic, just like how pre-renal injury after a while becomes acute tubular necrosis, and that's its intrarenal. So that's why it's hard to say whether it's in the liver or outside the liver. But I think that's a valid point, Yusuf, that is it more of a liver stuff because patient is appearing jaundice and less of a hemolysis? But in sick patients, maybe hard to make that distinction. Perfect. Erin, I think we are ready for the next helicopter.
Awesome. Okay. So for some additional history, his past medical history, he has hypertension, non-ischemic cardiomyopathy, anxiety, depression, no surgeries, no allergies. His medications are amlodipine, metoprolol, aspirin, Entresto, venlafaxine, lorazepam, and olanzapine, which happened to be added 2 months ago. Unknown family history, given that he's adopted, and he does not drink, smoke, or use drugs. For his physical exam, his vital signs showed a temperature of 97.9, pulse is 83, respirations are 25 per minute, blood pressure 151/87, his oxygen saturation is 99 on room air, and he has BMI of 33. For his general appearance, he's alert to person only. He's awake but confused, responding slowly to questions with one-word answers. He appears pale and diaphoretic. For HEENT, there is bruising and swelling of the left upper lip, and scleral icterus bilaterally. Extraocular movements are intact. For his neuro exam, he's awake and alert. His speech is slow, but we did not note any dysarthria, and there's no focal deficits noted. The rest of the physical exam was normal.
Perfect. Thank you. Thank you so
And I'll
much,
leave it
Erin.
with that. Yeah.
Perfect. Thank you so much. So to summarize that we had a 60-year-old gentleman who presented with acute to subacute onset of illness characterized by confusional state, some speech disturbances, non-specific gastrointestinal symptoms, including MSAs, and then patient also has some slurring of speech. And then we were wondering if there is something in the background data which can help us. So background data is important for two things. First, that patient has history of depression, and patient is not just like history of depression. Patient has active depression and patient is taking medications for that. This is important to know because often what happens that whenever we heard of the word depression, immediately we start thinking that is it one of the toxicities of the medications which could be causing this? But you also have to realize that depression itself is an illness. Like, what if the patient was so depressed that they tried to have a suicide attempt and maybe they took something more than what is appearing on the screen? So that's why it's important to know that, let's say this person is taking olanzapine. Now, what if olanzapine plus something X which can cause this syndrome? Patient was taking venlafaxine. So what if venlafaxine plus X can cause this syndrome? So we have one piece of the puzzle, and the other piece of the puzzle is hidden in the form of history of depression. So it's important to take that into account. Now, having said that, before we go to physical examination, if we just try to focus on that, what could happen if somebody is on like olanzapine or venlafaxine? So pretty benign medications, right? We give them like candies to so many people for so many different things. And often in med school, we think about, could it cause serotonin syndrome? But we know that in real world, those things are very, very less likely. But that is something which comes to my mind, right? That could this be related to the antipsychotic use? And sometimes olanzapine is known to cause extrapyramidal side effects and neuroleptic malignant syndrome, just like haloperidol, which is one of the classic antipsychotics. Although the risk is very low, but when people are on multiple medications, they can have neuroleptic malignant syndrome, and it is worth considering it given the fact that patient has been having subacute course of confusion, and there is something which can localize to the CNS as well. Second thing is all these medications can cause fulminant liver failure as well through drug-induced liver injury. And all of them can have different time course, and it depends on how much medications you are taking. So we would like to go back to the patient's bedside and ask them that, are you overdosing it? Are you taking it at the right frequency? What's going on? So that's regarding medications. And in the physical examination, maybe I can focus on this speech part, which was kind of slow. And then I will ask Yusuf to comment on the swelling of the upper lip and bruising. Like, what does he make of that? So for the slowness of the speech, again, it's a non-specific symptom because Erin clearly mentioned that there is no dysarthria, which means that there is no issue with the coordination. It's just the delivery of the speech is slow. So you start wondering that, does it mean that patient has global cognitive dysfunction with multiple regions of the cerebral cortex which are involved in the higher functioning of speech being involved rather than the particular areas like Broca's or Wernicke's or cerebellum itself which coordinates it. So as of now, given the illness which has been going on, no focal deficits on examination and no clear evidence of seizures yet, it's more likely that maybe this slowness of the speech is just coming from generalized CNS dysfunction. So it doesn't help us to make further progress, but it does make us wonder that if something is in the CNS, it's going to be diffuse. And if it's not in the CNS, then it could be any of the metabolic things which we talked about. So I will just like to throw one thing that in people who are really sick, you got to consider something known as acute disseminated encephalomyelitis. It's one of those diagnoses which is very evident once you do MRI. But before getting MRI, it's one of the tricky diagnoses. But in somebody who has no focal deficits, but is appearing really, really sick, then you should consider this diagnosis. And maybe now I will ask Yusuf that how does bruising and swelling of the lip factor into our discussion?
Yeah, thank you, Kirtan. I think there are two frames in thinking of this. The frame is the general prevalence of the population. So if any 60-year-old gentleman presents to the ER with encephalopathy, this is a suppurative bacterial infection or a meningoencephalitis in terms of prevalence alone. But here, just to factor in this patient's risk factors, which increase his exposure to other diseases slightly, but they're still not as common as meningoencephalitis or a common bacterial infection. So like you mentioned, serotonin syndrome with olanzapine. The other thing that can occur with olanzapine is a drug-induced hypersensitivity reaction or DRESS. And even though people associate DRESS with eosinophilia, the other things I recently learned is that leukocytosis is present in 80% of the patients with DRESS. And the other thing that's very common is actually facial swelling. 70% of patients with DRESS have facial swelling. So it's actually very common. And it occurs, the way I remember the medications that cause it, they're the anti-drugs, so antipsychotics, antibiotics, anti-epileptics. So olanzapine is one of those medications that, even though it's rare, can cause that. I'm keeping that in the back of my mind. That's not my on the top of my list, but that is on my differential for something that causes facial swelling in someone who we just started this medication. Other things I think of are like thyroid disease, and because we can also break it down to, is this like fluid, is this an obstruction, or is this like a other like glycosaminoglycans in thyroid disease? But I wouldn't put a lot of money in it on its own right now. I think I would at this point look for clues in the labs and the initial like CBC and chemistry, look for any eosinophilia, leukocytosis, any clue as to what's going on. And then as I look at those, I would consider what imaging I want and whether we need to do a lumbar puncture depending on where we go with the initial workup.
Perfect, good. And maybe Yusuf, I wanted to tease your brain regarding this part, that this person we know had a fall because of a near syncope, right? Now, we know that fall itself can cause some sort of trauma, but we also know that epilepsy or like seizures can also cause some kind of lip biting or tongue biting. So how common it is to have the lip lesions from seizures itself versus from falling? How has been your experience like?
I know that the lips themselves, it's the likelihood ratio is not very high, but the tongue biting, if you see like a bite on the tongue, that has a very high positive likelihood predictive ratio of a seizure.
Good to know. Thank you, Yusuf. Erin, we can get started with the next report. Thank you.
All right. I have some labs for you. Oh, well, I'll start with the EKG. Sorry. So EKG showed sinus rhythm with frequent PVCs. And then some labs. His CBC, his white blood cell count was normal at 8.1. Red blood cell count was 3.1. Hemoglobin was 9.3 with a baseline of 14 1 year ago. Hematocrit is 26.2. MCV, MCHC, and RDW were all normal. His platelet count was 13 with a baseline of 161. I have CMP as well. Glucose was normal. His B1 was 24 with a baseline of 14. Creatinine was 1.5 with a baseline of 0.6. Sodium is 132, potassium is 2.9. Fluoride, carbon dioxide, anion gap, calcium, albumin, and total protein are all normal. His total bilirubin is 5.33 with a direct of 0.62 and an indirect bilirubin of 4.71. His AST is 46 with a normal ALT and ALK phos. GFR is 47.3. I have more labs, but do you want to stop and discuss here?
Yeah, I think we can stop and discuss it. So Yusuf, what are your thoughts? Maybe you can start us this time.
Yeah, absolutely. So just to summarize the labs, we have a normocytic anemia, a significant thrombocytopenia, and some hypokalemia and worsening kidney function, along with indirect hyperbilirubinemia. The moment I see those labs, I'm holding my breath and I'm thinking of things that I want to rule out immediately before I go down like the rabbit hole of rare diagnoses. So things that are extremely common in this case is like the anemia and the thrombocytopenia are linked because the platelets are clumping and causing the hemolysis. So I think of things like a TMA, a thrombotic microangiopathy, or DIC. And I do think that DIC is still significantly more common than TMA, just because of how common like infections are. Like, it's much more common to get a staph bacteremia causing DIC than getting TTP, for example. But the differential also includes so TTP and HUS, and we see here we have like the pentad is starting to form. We have the encephalopathy, the indirect hyperbilirubinemia, the AKI, the anemia and thrombocytopenia. However, to keep the differential broad and not to miss anything else, could a cholangitis still be at play here, for example? It's less likely to cause like this degree of thrombocytopenia without a obvious signs of bacteremia. And we see here also there's no exposure to heparin to think of anything that can cause like a heparin-induced TMA. And in the back of my mind, I'm starting to think, are there any like secondary causes of TMA? We know in this case, we don't know about any history of malignancy, for example, or any other exposure to a medication that can cause that. So what I'm thinking right now is I would want a smear as soon as possible, basically. And even then, that might not necessarily be sensitive enough. So I would like initiate a infectious workup. I would get a smear. The smear is not sensitive for TTP because it takes sometimes multiple smears to find schistocytes. And if you're considering it an Adams TS13 level, it takes a week to come back. So this is one of those diagnoses where if you don't find an alternative diagnosis, you want to start treatment, consult your specialist, and then send out the lab test and wait for it basically with time. And in the meantime, I would want to initiate like a workup, like an infectious workup with like blood cultures and look for signs of clot. What are you thinking, Kirtan?
Perfect. Thank you so much, Yusuf. I love how Yusuf prioritized that what should be done in terms of management rather than going down the rabbit hole. And I agree with him that if you get such patient, let's say overnight in the ICU, then rather than taking the pen and paper and thinking about all the differentials which could do this, the first thing which people recommend is getting a score which is known as plasmic score. So that's a score which has been devised to figure out that what's the probability of TTP based on the evidence which you have, and what's the utility of getting the plasma exchange as soon as possible, which could be life-saving. Because if you think about it, sending ADAMTS 13 levels to rule out TTP takes at least 7 days. Like no matter which lab you send it to, it won't come right away. And TTP is something which could devastate somebody in matter of few hours, if not days. So you can calculate the plasmic score, and there is a very good online calculator which takes into account the patient's age, whether they have history of cancer or not, how high is bilirubin, how high are their platelets, and based on that, if the score is in the intermediate to high range probability for TTP, then giving plasma exchange is recommended, because plasma exchange is not like giving steroids. It's like not going to worsen any infection. Plasma exchange has its own risk, but still it's not going to make somebody devastatingly ill if they have something else than TTP. So it's worth pursuing it. So I agree with Yusuf regarding that. The second point, which actually I learned from Ravi, who is our mentor, is that whenever we see the platelets low and hemoglobin also low, apart from this big bucket of TMA, what are some other things that we should not miss? So one important thing is considering something known as combination of ITP and autoimmune hemolytic anemia, which is also known as Evans syndrome. So it is basically just an autoimmune attack directed towards both your RBCs and platelets. And what can drive it? So usually some autoimmune diseases or hematologic malignancies can drive it. Now, in our case, the reason why that becomes a little bit low on our radar is it doesn't really cause a systemic signature, kind of like our patient. Like you could have Evans syndrome, but that's not going to make you have confusion and have speech deficits and things like that, jaundice and all those things, which is a little bit unusual. So, but still something to keep in mind. The third thing which I always tell my medical students is that we try to trend the labs, right? So what we are seeing is a snapshot of a patient. We know that patient has bicytopenia as of now. But let's say if you follow this patient for 2 or 3 more days and you start seeing that WBC is also going down, then suddenly you are in a different territory altogether. From bicytopenia, you are now going to pancytopenia. And what are the differences of pancytopenia with indirect hyperbilirubinemia? So you start going into the territory of something known as ineffective erythropoiesis. So basically, you are looking at the bone marrow problem, which is causing this ineffective production of the red blood cells, causing a hemolysis-like picture, but not hemolysis. It mimics hemolysis. And what are the things which should be on top of our differential in somebody who is 60 years old? So things would be metastatic hematologic or metastatic solid malignancies. So people who have, let's say, leukemia, who have myelodysplastic syndrome, often they can have ineffective erythropoiesis and they can mimic TTP. People who have metastatic solid tumors like metastatic prostate cancer or metastatic pancreatic cancer, sometimes they can trigger DIC-like state, which can mimic the TTP. So this will be the must not miss diagnosis: hematologic malignancies and solid malignancies. Third thing, that what are some of the further tests we can do to refine our hypothesis? So I think the one of the important things we could do is get the Coombs test to figure out if it's positive or negative. I'm sorry if it has already been given, but Coombs test will be important to figure out, because if it's TMA spectrum, then by definition, Coombs test should be negative. And if we are going down the rabbit hole of TTP, then maybe before I share my thoughts, maybe I will ask Yusuf that what are some of the further investigations apart from ADAMTS 13, which you usually like to get in people with TMA spectrum?
Like you mentioned, the
So
Coombs. Oh, sorry, okay. Sorry, Aaron.
no, go ahead.
I don't know, please, you can go ahead.
I was just going to mention some of the tests that you would want to order. So we would want to get a reticulocyte count. Haptoglobin could be important. Obviously the peripheral blood smear, but the things in the plasmic score that we look for to indicate hemolysis. I did add there was a couple more labs in this aliquot that are up that I figured I could just share with you real quick. So PT is 13.8, PTT is 20 is normal, INR is 1.22, His haptoglobin was less than 8, normal troponins, negative urine drug screen, a positive hemocult, and then a UA positive for blood, glucose, protein, hyaline cast, and granular cast.
Thank you so much. Thank you for confirming that the patient has hemolysis, because haptoglobin is the most sensitive marker, and of course we assume that that's the case, but here we have actual evidence of it, and we have the INR is slightly elevated. And so other things I think of is a thorough history. I think that that's helpful from the family members. Like, do they have symptoms of scleroderma for 10 years that haven't been noticed? Do they have like interesting things that can cause it are like tick-borne illnesses? So I just take like a thorough history about travel, hiking, things like that. A fun one is like a quinine induced, like if they drink a lot of quinine, like tonic water, they might develop a TMA, but and then hypertension on its own. But all in all, this doesn't necessarily change the management unless you find something secondary. The other big thing is lupus, like catastrophic antiphospholipid syndrome, more common in like women than in men, and typically you would have other manifestations prior to the TTP, or you would typically find like recurrent pregnancy loss, clots, things like that. But these are the things that I would ask for, and that's mostly it.
Perfect. And sorry to throw you to you back, Yusuf, but what do you make of frequent PVCs? Like, do you think it's a red herring, or do you think it could be something real?
I don't know. I think with the I would want to like fix the potassium and then watch if like they're persistent or not initially. What do you think?
Excellent. I agree with you, Yusuf, that maybe it is just driven by the systemic inflammation and electrolyte imbalances. And often in patients like this, so many things are going on that I won't be surprised even if their EF is slightly low, so-called, stress cardiomyopathy. It often happens in these people. So not to put much weight on it, but if we start seeing that these PVCs are getting transformed to like non-sustained ventricular tachycardias or like few episodes of VTs, then that would be concerning for real myocarditis, and then we can expand our spectrum. But I agree with Yusuf that usually in such scenarios, getting a very, very thorough drug screen of even the things which you cannot detect in urine, because so many synthetic drugs you cannot detect in urine, and so many of those drugs can trigger the TTP-like state. So getting a drug history will be important, and autoimmune like ANA, very important, and APLS serologist would be good. And one important point I wanted to make was that in diseases, when we are evaluating them, we always look at the epidemiology. So like TTP is something which can come at different ages, and some people say it has a bimodal distribution, but still it is generally seen in people who are younger. So when you see so-called TTP-like state in people who are above the age of 50, then you always wonder that is it because of so-called ADAMTS13 inhibitors, which means that you have some mechanism of dampening those ADAMTS13 functioning. So one way is what Yusuf said, SLE can cause autoantibodies against ADAMTS13 and dampen its function and can cause secondary TTP. Other possibility is that people can have autoantibodies of malignant source. So people who have plasma cell neoplasms, like be it multiple myeloma, monoclonal gammopathy of undetermined significance, often they can mount these antibody responses against ADAMTS13, and which can present like this. So in such people, often getting SPAP and immunofixation would be very important, apart from ANA and antiphospholipid. And last thing, I would also, to complete the workup, I would also like to get the ferritin, just to make sure that we are not missing, like let's say this person's ferritin comes out to be 10,000, and then you are looking at HLH kind of states, and which can often mimic the TMA kind of situation. So that would be the next investigations which we would like to get. So yeah, Erin, we are ready for more investigations.
All right. So some additional labs, the ammonia was normal. The ANA screen was positive and the Coombs test was negative. Some imaging, we got a chest x-ray, a CT of the brain, CT cervical spine, and then a CT abdomen pelvis given the positive hemocult. And all of these images showed no acute findings. And then our next aliquot is going to reveal the final diagnosis.
Okay, perfect. Thank you so much, Erin. So guys, let's summarize that what are we dealing with, and then maybe I will ask Yusuf to share his final thoughts, and we'll also look at the chat, get the ideas from the chat as well, because I think we have enough time today. So we had a middle-aged gentleman whose past medical history is relevant for depression, non-ischemic cardiomyopathy, who is on some psychotropic medications and who presented with acute course of illness characterized by some CNS symptoms, GI symptoms in terms of jaundice, and they had constitutional symptoms as well. When we did the examination, we found out that the examination is actually non-focal and there is nothing screaming out that there is something structural going on in the brain. So we came to the conclusion that maybe this is driven by the systemic factors affecting the CNS rather than intra-CNS problem. Then we looked at the labs, and through close scrutiny of the labs and some imaging studies, we came to the conclusion that we are indeed dealing with what seems like a true TMA state, given that Coombs test is negative. And based on the information which Erin has given, looks like WBC has stood its place. It's not going down. So it's not pancytopenia, it is bicytopenia. And the ANA was positive. Now, Erin hasn't given us the sub-serologies. So that would be something which we would discuss about, that was it just ANA positive, like 1:80, 1:160, or is it like 1:2000? And then the serologies are also positive. And some things here and there, patient had occult blood in the stools, patient had frequent PVCs as well. So I would just like to make a quick comment on the heme occult blood test. Now, we know that every test has false positive and false negative, and there are so many things which can cause false positive heme occult and so many things which can cause false negative that sometimes you lose track of them. So in such situations, the best thing to do is repeat the heme occult test once the person has stabilized, and then see if it's still positive, then you might want to do an endoscopic evaluation to make sure we are not missing anything else. Now, people who have severe thrombocytopenia, they can have some degree of mucosal bleeding and they can have hemoccult blood test positive. It's not very common, but it's not even unheard of. So that is something which I would think about as of now rather than putting too much weight on it. Second thing is, I would like to see for any discrepancies between our illness script and our patient's presentation to make sure we are not missing anything. So what Yusuf was alluding to from the first aliquot itself, like he got this like sixth sense, like instincts that this could be TTP like state. Now, is everything compatible with TTP? So I think that as of now, things do look like TTP. The only thing was the age part. Now, the ANA, can that be a clue that is it possible that somebody who is male can have lupus as the index presentation of TTP at the age of 60? It's certainly possible, but it's a little bit less likely. And if, let's say, ANA titers are really high, then you really start wondering that we know that autoantibodies at the old age is all driven by the malignancies. So is it possible that this person has some sort of occult hematologic malignancy, which is driving this autoantibody production with ANA being positive and TTP also happening? So that is certainly something which is reasonable. And I would like to know more if any lymph nodes were palpable or not, or if any on peripheral smear, there was any evidence of teardrop cells or any blasts which could guide us regarding hematologic malignancy. ANA being positive also raises the suspicion that what if this person has secondary APLS, because ANA and APLS are kind of like brothers and sisters, they go hand in hand. So we would like to get the beta 2 cardiolipin, beta 2 glycoprotein, and also the lupus anticoagulant levels to figure out if this person has APLS or not. And maybe we can take it from there. So Yusuf, what are some of your thoughts before we go to the final diagnosis?
Amazing discussion, Kirtan. I think my final thoughts are like uncommon presentations of common disease are way more prevalent than common presentations of uncommon disease. I was just looking it up. The prevalence of DIC is 1% of all hospitalized patients, while the prevalence of TTP is 3.7 persons per million. So this is in the all comers. If anybody comes to the ER, will more likely be a DIC secondary to the staff than being a TTP first presentation. But this is the classic presentation of TTP, and I think we don't have any other signs of like inflammation that we see. We don't have any signs of fever. So I think, especially like Noah mentioned, like someone presenting at morning report is like TTP is much more common. I think what I would want next is like a smear, like you mentioned. The ANA is not moving my differential diagnosis that much, unless Aaron tells us that the titer on the next aliquot was 1 to like 2000. I don't think it's gonna change. Up to 20% of the population has a positive ANA. It's associated with a variety of conditions. It's also associated with like many conditions that are related with acute inflammation, for example. So I wouldn't hang my bucket on that, but it is on. That's where I am right now. I think I'm calling hematology / looking at the smear myself and transferring this patient to the intensive care unit, and I would label this as TTP.
Perfect, good. And Yusuf, like maybe I would ask you even more that do you think we could label this as primary TTP versus secondary TTP? Like primary TTP meaning like ADAMTS13 itself is like not functioning in some way. Secondary meaning something else is driving it. Like what's your gut instinct?
I like to ground myself also in prevalence. So I sent the prevalence in the chat. It's actually 50% of TTP is secondary and 50% is primary. And here we don't see any other risk factors. So it's still 50-50, but I'm voting on primary.
Perfect, good. So I think I am with the Yusuf that it's like coin toss, right? You cannot figure out. So what are the final things that we would like to do? So what Yusuf said that you would get the ANA titers, sub-serologies, APLS serologies. You would like to get the ADAMTS13 levels and the function, both of them. Probably go again, patient's bedside, ask about any drugs. And then finally wait to make sure that the SPEP and anything else doesn't reveal any hematologic malignancy. So yeah, I think that would be our last stuff, and maybe curious to hear more about you. That Erin, what was like it like for you to take care of this patient, and how was your team thinking by taking care of this patient?
Yeah, so with the ER perspective, it's funny at the beginning we had talked about how we would be concerned, with the stroke alert given the slurred speech and possibly falling with the bruised lip. So the CT brain was actually done pretty early on. We were more focused on the acute setting and consulted hematology pretty quickly, got the patient admitted to the ICU, and we worked with hematology on what labs to order. We did get a titer of the ANA. I didn't include it, but I do have it for you. It was 1 to 40, so not too astonishing there. And if you want me to, I can reveal what we did do next to find the diagnosis. So I have the peripheral smear. We had which showed reduced platelets without platelet clumping, positive for schistocytes and fragmented are red blood cells. And next we got an Adams TS13. The Adams TS13 activity was less than 0.03, and there was the presence of an Adams TS13 inhibitor with a level of 3. So the diagnosis, you guys nailed it. It was TTP, and we admitted the patient to the ICU, where he received his plasmapheresis. He was followed by multiple people during this hospitalization, including hemonc, nephrology, neurology, and cardiology. His platelet count did increase with the plasmapheresis, and his neurologic status slowly returned to baseline over the next 5 days. However, on day 5, sadly, his platelets dropped again, and he did start to develop the slurred speech. So we did a head CT, which revealed acute embolic strokes. Neurology determined that these strokes were likely secondary to the TTP. Ultimately, the patient was transferred to a tertiary care center to take over. We were at a small community hospital, so seeing something like this wasn't too common, and had us all putting our brains together to try to figure out what to do. I ended up learning about the plasmic score and some really cool things. So I liked hearing how you guys took on this case and keeping your differential really broad, despite pretty much knowing he was on the front line.
Thank you so much, Erin, for highlighting that how it was like for you to take care of this patient and how longitudinally following the patient is very important. So before we share our final thoughts, maybe I can ask Master Yusuf, who figured this out very early on, that Yusuf, what do you think about this case? Like, how would you manage this patient? And what do you think about these strokes?
Yeah, thank you so much, Aaron. This is an amazing case. Thank you so much for bringing it. It's also exciting for your emergency room career in the future. You're going to be seeing so many patients in their first presentation. You're going to be the person thinking about them and the differential diagnosis. And thank you so much for bringing us the case and helping us learn as well. I agree with the management, like the treatment is usually like plasma exchange, and sometimes more immunosuppression is given as well, like glucocorticoid, sometimes rituximab as well. I think it's also like unfortunate that the patient developed like strokes, and unfortunately, this is a common complication of thrombotic microangiopathies. Many of them, although we think of as like thrombocytopenia as like a condition that causes bleeding, for example, but it also causes thrombosis and can be very, very common in these conditions. Any reflections you had, Kirtan?
Perfect. No, I agree with Yusuf that sometimes in people like this, when you have presence of inhibitors, then you know that something is producing those autoantibodies. So there is this think that we maybe can suppress those clones of B cells or plasma cells which are producing these antibodies. So that's why people receive steroids, people receive rituximab. And some studies suggest that giving something known as caplekizumab, which is a monoclonal antibody against the von Willebrand factor, because we know that the whole pathogenesis of TTP hinges on the fact that your ADAMTS13 is not able to cleave the von Willebrand factor, and all these mega molecular multimers of VWF stack up in the circulation and cause the clotting. So you could imagine that if you form an autoantibody against the VWF, then you will interrupt this cycle and you could prevent the relapses and prevent the complications. So some studies suggest that adding caplekizumab to the regimen of the patients who have TTP helps in preventing further complications. And regarding strokes, just one quick thing I wanted to mention was that in TTP, like there are multiple ways in which strokes can happen, because usually we think about its embolic stroke, as Yusuf said, because of thrombotic occlusion of the microvasculature. But TTP is also known to trigger what is known as RCVS, like reversible cerebral vasoconstriction syndrome, because TTP is all about deranged innervation and deranged autonomic nervous system functioning at the level of posterior circulation. So people can develop this segmental constriction of the cerebral vessels. And we have seen people who presents with RCVS, multiple strokes, and then you do the workup and retrogradely you find that they have TTP. So often in such cases, some studies suggest that getting magnetic resonance angiography is important rather than just MRI, because if you just get MRI, you will look at the parenchyma, you will see the strokes, and it will look embolic stroke because it will be disseminated, and that's how RCVS also present. So sometimes that is one of the mechanism which is implicated. So interesting to see that patient had that, but fortunately, with the right treatment, hopefully patient recovered fully. So maybe I can ask Erin that if you got a chance to evaluate this patient in outpatient setting and how was he doing?
Unfortunately, I don't have access to how he was doing outpatient, which was a bummer for me, just being curious and hoping the best for him. But I hope he did get good care. He did go to a pretty awesome institution.
Perfect. Thank you so much, Erin, again for a wonderful case. I wanted to thank Yusuf for discussing with me. I really loved how Yusuf nailed the diagnosis in the first record itself with the reflex type 1 thinking. So, which is kudos to his clinical reasoning skills. Thanks to Erin for bringing us the case. Perfect way to start the journey after submitting the ERAS application. We will never forget this brilliant case that you presented. Thanks to Vale for helping with the scribing. And maybe I can pass the mic to Vinny to do the teaching points.
So amazing discussion, guys. Congrats on the presentation, Erin. And so our case started about a patient that was presented with a mood factorial and diverse component of manifestations. And we focus if the confusion would be the center of the case or would be just noise. And just lead us to thinking if this is in or outside of the CNS. And we need to add the component that this could be a subacute or acute subimposed clinical situation on subacute. Then we could see about the associated symptoms such as vomiting and jaundice that our patient had. And we can correlate that with high clinical pressure and a sepsis component. Besides, we try to look for other signs of TTP, pneumonia, viral nephritis, infections, and possibility of toxic exposures, microangiopathic hemolytic anemia. And we could correlate that to jaundice, thyroid diseases, and autoimmune diseases. So we'll start with just some basic panel and looking for alterations in electrolytes and basic chemistry, steroids or any meds, and if try to see if the patient is hypoglycemic and is in a more complicated state of a multi-organ failure. So imaging would be priority here, and we need to evaluate if there is any need to a lumbar puncture. Besides, we need to evaluate the history of depression that the patient present and correlate that with his medications and possible inhibition or induction of the CYP450. Olanzapine is a medication that the patient use it and can cause extrapyramidal side effects and neurologic malignant syndrome, serotonin syndrome, precipitate any other acute liver injury when associated with other medications, and some drug reactions such as stress that can manifest with clinical with facial swelling. Besides, we need to dive in deep in the past medical history, and we can also affirm that tongue bite is a very specific for seizure. So this will could indicate something for us, and we'll proceed to see if the patient has a global cognitive dysfunction, and we'll present with some Broca's signs or Wernicke signs and try to differentiate that for focal deficits. So if the deficit is in the CNS, we'll present with diffuse symptoms, and if it is outside of the CNS, we'll present with more focal symptoms. Besides, we can see that our patient had anemia and thrombocytopenia, and we'll need to differentiate between DIC and thrombotic microangiopathy, and related that with malignancy, medications such as heparin, and hemolytic uremic syndrome, and TTP. The patient had a first sign that it was the encephalopathy, and the TT of the pentate of the TTP that is composed by fever, renal dysfunction, hemolytic anemia, and thrombocytopenia. Besides the encephalopathy, Kirtan told us about the plasmic score that will indicate about the probability of the TTP, and our patient had a plasmic score high, and then we'll see the evidence of MAHA and thrombocytopenia. Another thing that was common also was about the Evans syndrome. That is a syndrome that presents with bicytopenia and has also low platelets and low hemoglobin. This could be related to the autoimmune hemolytic anemia, immune-mediated thrombocytopenia. We'll also present with a DAT and signs of hemolysis. So the patient we need to think if this is hemolysis, that is, if we have a case of hemolysis or this is a sign of bone marrow failure, and try to correlate with some possible alternatives such as myelodysplastic syndromes, leukemia, and mimickers of TTP. Finally, our patient was revealed to have a TTP, and he's above 15 years, and we thought to differentiate about primary and secondary causes. And then there is a 50-50 chance, as was common, and the primary would be by a atom TS13, and the secondary would be mainly drove by autoantibody of malignant hematologic and solid origin. And we need to proceed with some tests such as immunofixation, ferritin, ANA, and blood smear. And Kirtan also commented about the pathophysiology and the autoantibody against the VWF, the possible treatments that will act on this target. So finally, the treatments are mainly composed of glucocorticoids, rituximab, eculizumab, and plasma exchange. So that's all. Thank you.
Thank you so much, Vinny. Thank you, Vale. Thank you, Aaron. I hope you all have a wonderful evening or day wherever you are.